Hi, this is Mark Hendrix, and today we're going to talk a little bit about recovery-oriented treatment planning. So what does it mean to be recovery-oriented? Being recovery-oriented in this context really means recognizing the importance of and incorporating the experience of an individual, couple, or family that's receiving services. Experience is really in reference to thoughts, values, beliefs, emotions, history, culture, preferences, strengths, trauma, and spirituality. So it's important to recognize as we go through that and what we, in incorporating experiences, is to consider the difference between a traditional medical model approach and a recovery-oriented approach. And so the difference there really lies in how we look at people, the difference in what we expect as clinicians versus what individuals expect for themselves. And so here we have some examples of the difference between oftentimes what we expect for a patient or a client versus what we expect for ourselves. And what recovery-oriented treatment planning does is really bridge the gap to bring those two things back in line with one another. So what we expect for clients oftentimes is very different than what we would expect for ourselves. So traditionally we expect compliance with treatment, decreased symptoms and clinical stability, better judgment, increased insight, reduced aggression, and acceptance of their illness or disability, adherence to treatment recommendations, decreasing their hospitalizations, abstaining from substance use and abuse, active engagement, showing up to their appointments, improved functioning, and realistic expectations. Where what we expect for ourselves as people is a life worth living, a spiritual connection to God, others, self, being a good mother, father, child, spouse. I can't stress enough the importance of incorporating those roles in treatment planning. Having friends, having fun, laughter, nature, music, hobbies, joy, love, intimacy, having hope for the future, giving back, being needed, learning, having a home. So how do we start by promoting recovery through the treatment planning process? Well, it starts with our perception of what people experience and what people need, and how that is incorporated into the services that we provide. So we promote recovery by understanding that people seeking counseling and those with mental health problems and addiction issues generally want the exact same thing as the rest of us. People want to thrive, not just survive. Recovery-oriented care challenges us to move past the maintenance of clinical stability to the true pursuit of recovery, which is regaining those life roles and having a life that's worth living. Recovery is inclusive, and at its core is the belief that a person seeking treatment is able to reclaim their life roles and pursue the life that they desire, not just the best life that we as clinicians think they can achieve. Where treatment is prescriptive and assumes the clinician has all the answers and knows what is best, recovery assumes that the person receiving the services is the expert in their own life. So recovery-oriented practice, what is that? Well, it adheres to person-centered principles in the process. The person should be a partner in all planning activities. It should include education and preparation regarding the treatment planning process and what to expect. It should give the person reasonable control over the logistics, the time that it takes place, who they want involved, etc. The person should always be given a written copy of their plan. And it's really important to recognize that the language we use in treatment planning, and not just in treatment planning, but also in the treatment and services that we provide, is a key component of recovery-oriented practice. So some things to look out for. Be aware of your language. You know, we have deficit-based language and we have strengths-based and recovery-oriented language. So where deficit-based language might refer to a person as a schizophrenic, a borderline, recovery-oriented language would refer to that client as a person first. So it's a person living with schizophrenia, a person diagnosed with schizophrenia. So instead of saying, a drug addict, a substance abuser, a person struggling with alcohol, or a person struggling with drugs. If you're working in a treatment team setting or an interdisciplinary setting, instead of a treatment team, it's a recovery team. And looking at a person as high functioning versus low functioning, versus a person whose symptoms or addiction interferes with their ability to do something within their life. A big one is, unrealistic expectations. Sometimes we think the clients that we work with may be unrealistic in what they're trying to achieve because we have a clinical picture of what their capabilities are, and it's important to recognize that our opinion doesn't really matter as much as theirs. So, referring to those people as idealistic, ambitious, having high expectations is a better way to phrase the challenges that people face. A person who's resistant or non-compliant, or maybe that's a person who disagrees with taking medication or disagrees with the approach that we take in counseling and maybe chooses an alternative. Looking at weaknesses versus barriers to change, maintaining clinical stability, abstinence, or promoting a life worth living. Instead of referring to somebody as irresponsible or impulsive, or maybe you categorize that and perceive that as somebody who takes risks, tries new things. So it's important to remember that recovery-oriented treatment plans focus on what people value most in life. And some good examples of that is an ability to manage their own life, having some social opportunity, being active, having a sense of accomplishment in what they're doing, some spiritual fulfillment, whether that's religious or not, a sense of purpose, belonging, having a quality of life, having access to educational or learning opportunities. Work is a huge thing. Being healthy, having some self-care, a sense of well-being, and being in a relationship, having a sense of intimacy and connection to other people are some good examples of what people really value. A good litmus test for this is when we conceptualize the people we work with, look at it through the lens of what are their values versus what do we expect for them. So treatment versus recovery. Treatment is something that we provide to people. Recovery is what people accomplish. So some examples here of the differences between maybe a medical model or a traditional treatment plan and a recovery-oriented plan would be, a goal would be under a traditional treatment plan for that person to maintain stability. Again, you'll notice that is our goal for them, not their goal for themselves. And so we might have objectives under a traditional model where we, prescribe for them to attend appointments as scheduled, and take their medication as prescribed, and adhere to their therapist's recommendations. Where recovery is going to look at, what's important to that person? What do they want to accomplish? And so that might be reconnecting with their children. And so what would the objectives look like for that? Well, through the counseling process, they might learn and apply strengths-based communication skills to improve the connection and trust with their children over the next 60 days. And develop bonding routines. Set aside time for them daily over the next 2 weeks. And so you see the difference there between prescriptive treatment and person-oriented care. Things to assess in recovery-oriented treatment planning include, obviously, what is the presenting problem? Why are they coming to counseling? Why are they seeking care? What are their physical health issues? What's their readiness for change? And oftentimes that's talked about in the context of substance abuse treatment, but it's also a good tool to look at a person's readiness for change in any area of change. Are they in pre-contemplation, contemplation? Are they already taking some steps to prepare to change? Maybe they've already implemented some things around what they want to change. And then, of course, maintenance and relapse. Recovery, it's important to remember, is not a linear process. Incorporating their individual preferences, either for or against specific interventions. And a big one is who do they want involved in their care? And do they want their family or other collateral contacts involved? Maybe they would like somebody, a friend or a spiritual leader to be involved in their care as a support. Considering their unique needs, whatever those might be, their cultural background, and obviously their strengths. What are they good at? People have a tendency to grow in their areas of strength at a much faster pace than they do in their areas of deficit. So a strengths-based approach is one you should always take. So when we look at those concepts and how we put the pieces together in recovery-oriented planning, so what does that look like? How do we put together a treatment plan using a recovery-oriented process and perspective? Well, it starts with a goal, but that needs to be defined by the person. It doesn't need to be overly specific. It can be broad. It can be general. It can be, in our opinion, unrealistic. We need to incorporate the strengths to draw upon, but also not ignore the barriers or the needs that interfere with the steps that that person is taking towards their goal. One key thing to remember is objectives are what the person that we're working with does to accomplish their goal, and that should fit the SMART criteria. Those objectives need to be specific, measurable, attainable, realistic, and time-framed. Those interventions and methods, action steps should be incorporated professional or billable services. There should be an emphasis on clinical and rehabilitative supports. Interventions are what we do to help that person accomplish their objectives and overall their goal. So incorporating the action steps for the person in recovery, as well as the roles and actions of natural supports. So generally speaking, goals are a broad general statement that expresses the desire for change. It need not be anything other than that. The goals are long-term and written in positive terms. Ideally, they capture the person's own words. We want the person to come through in a treatment plan. You want to be able to see the wants, needs, desires, and the uniqueness of that person in their plan, because at the end of the day, it's their plan. It's not our plan for them. It's developed conjointly. Sometimes those goals may seem unattainable or unrealistic, and that's okay. Goals are not problem-focused. They should reflect accomplishment rather than the absence of symptoms or problem behaviors. So, common errors with goals, oftentimes we try to incorporate too many goals. Maybe the goal is provider-centered, not person-centered. Oftentimes goals that are developed in traditional treatment planning are not inclusive of the concept of recovery. They're not reflective of a need or a desire for change. They don't include the person's strengths, or maybe they're overly broad. They don't capture that desire for change. So let's talk a little bit briefly about addictive disorders goals. In concept, it really shouldn't be that much different, but there are some things to point out. Developing goals can be a major challenge at times for individuals with co-occurring disorders. So maybe they have a mental health issue and they also have a substance abuse issue. So we as providers, oftentimes, we see a substance abuse problem that's interfering with somebody. We want to jump straight to abstinence from using drugs or alcohol completely. That may not be realistic for people at that point in time. It's important to meet people where they're at. Again, keeping in mind that Prochaska and Clemente's stages of change. Plans for harm reduction should take priority over demands for sobriety. And again, recognizing that stage of recovery that the individual is at. So objectives. Objectives oftentimes get confused with interventions, but they should a good objective always follows the SMART criteria, which is specific and concrete action-oriented steps. They should be measurable or quantifiable in some way. They need to be attainable, feasible, and realistic. And it's important to make them time-framed, meaning when is the goal date for this objective to be accomplished? Objectives are the steps taken towards the goal. They're described using action words. So Charles will, Tina will do something, whatever that something might be. Objectives are what the client does to work toward their goal. Objectives are defined as a part of a collaborative process. They are not prescribed solely by the clinician and should include input from the client. So in your treatment or recovery-oriented treatment planning process, it's important to seek feedback. Ask the person you're working with how they feel. Do they feel that that's realistic? Do they feel that that incorporates what they want to accomplish? And attainment of the objectives is, again, it's supported by the intervention. So remember, objectives are what the client does. Interventions are what we as clinicians and providers do to help them accomplish those objectives. So some tips for writing objectives. Objectives should reflect valuable and meaningful change. They should have a target date for accomplishment. And at the end of that target date, a review, or even before, a review of goals and objectives will indicate whether to resolve or continue the objective. That process should be fluid. A recovery-oriented plan is a living document. It's something that can change based on the needs, the wants, and the desires of the person you're working with. They should focus on increasing the use of strengths, skills, and resources rather than focus solely on reduction of symptoms, problems, or failures. So a good way to think about that is your client coming in to meet with you. If every time you're just talking about, Okay, how many times did you lose your temper today? Um, that's pretty deficit focused, as opposed to how many times did you have success in managing your anger today? That key concept here is that if you increase success, failure reduces as a result. Don't fall into the trap of measuring success to the reduction or absence of failure. That's problem focused. A big thing here is to avoid the dead man standard. And so what do I mean by the dead man standard? Well, the dead man standard is if a person dies, will that problem stop? So example, if John's having temper tantrums and our objective is for John to stop having temper tantrums, the dead man standard would be to ask yourself the question, well, if John were to die, would he accomplish his objective? You want to stay away from that. They should describe positive, active change. Don't confuse objectives with interventions. Objectives are what the client does. Interventions are what we do to help them. Goals can have just one objective, but really shouldn't have more than 3. It needs to be able to be processed and worked towards, not overwhelming in nature. So again, interventions. What are interventions? They're the activities or services provided that help the individual achieve goals and objectives. And it's important to remember that if you're working within a treatment team, those interventions need to incorporate what the other members of the team are doing to help support the individual's defined objectives and goals. They're the methods by which the plan is executed. Where the objective is what the client will do, the interventions are what the clinician and other members of the team do. They describe what the service is specifically, who's going to provide it, when it's going to be provided, where it's going to be provided, and why it's going to be provided. What's the purpose? How is this going to help reach your goal? So a quick word here. Well, you might be asking yourself, well, what about those negatively motivated people who don't seem to want to change? Maybe they're using drugs, they're staying in bad relationships, we think they should leave, etc. Well, that's okay. Meet people where they're at. You can use motivational interviewing to promote a desire for change, and give authentic feedback. Take another road and don't let a power struggle become the only focus of the conversation. If you find yourself arguing with your client, you really need to take a step back and reevaluate what you're doing. So some principles of intentional care. It's important to keep these concepts in mind, not just when you're providing services, but also in the planning process. Individuals deserve to have the dignity of risk and the right to failure. But they should not be abandoned to suffer the consequences of that failure alone. Neither providers nor the people we serve are failures if a choice results in a failure. Failure is an experience. It does not have to be definitive for that person. Most individuals learn and grow from risk-taking and learn from both successes and failures, just like we do. So in summary, goals are broad, general statements that express the desire for change and improvement. They're long-term and written in positive terms. They're ideally captured in the person's own words. They do not need to be measurable or have a time frame. They sometimes might be unattainable or unrealistic in our opinion. Goals are not problem-focused. They should reflect accomplishment rather than the absence of symptoms or problem behaviors. Objectives are what the person does to achieve the goal. And again, follow that SMART criteria. Interventions should describe what staff members or clinicians or providers within a treatment team do. Again, the what, who, when, where, and why of what the service that we're providing to help support them.
Hi Mark, thank you so much for being here today. Tex-CHIP really appreciates having you. We appreciate your expertise. So thank you for doing your wonderful presentation. I think now what we'd like to do is move into just a little bit of a discussion portion. So before we get started, would you go ahead and sort of introduce yourself and let our audience know where you work and a little bit about yourself?
Sure. Thank you, Julie. I appreciate the time taken to allow me to be here and meet with you guys. Again, my name is Mark Hendrix. I'm the Director of Adult Mental Health Services for the Oasis Center for Mental Health and Intellectual Disability, which is the local mental health authority here in Oasis County. I've been in the mental health field for a little over a decade. Kind of started, I'm a double alumni from this university with undergraduate and graduate.
Awesome.
And so I kind of started, went to work with my bachelor's degrees and worked as a case manager, and I came back to school and got my master's degree and became licensed as a professional counselor. And throughout that course of time, I've just kind of done a lot of different positions, both in management and direct care. I also work for a local counseling agency where I do family, individual, couples counseling.
Okay.
And so I've done a little bit of stuff both in clinical mental health and just general counseling.
Fantastic. Well, thank you again for being here. So kind of, I guess, piggybacking on that, can you tell us a little bit about, so you presented today on recovery-oriented treatment planning. Can you tell us a little bit about how your previous experience either contributed to that, or it was kind of a totally different experience? Can you tell us a little bit about that?
Yeah, so when I first started working in clinical mental health, it was still, it was not quite, it was just before the recovery-oriented care kind of rolled out, and so we were still kind of stuck a little bit more in a traditional medical model of care. And so a little bit of what I talked about in the presentation is the differences in perspective between those two things.
Right.
And so it really kind of having seen that transition from more of a medical model into a recovery oriented model is eye-opening, and kind of going through that process. And I was a bachelor's level mental health professional, and then recovery-oriented care kind of came about, and I'm still working in clinical mental health, and I came back to school to get a master's in counseling and become a therapist, and so just kind of seeing the evolution was really valuable, because I think when you look across the system of care, you still see a lot of that.
Right.
You still see a lot of perspective in not just treatment planning, but in treatment and therapy in general. Of the clinician or the physician is the absolute expert on what that person needs to do, and so it's not very inclusive of an individual's experience and what they go through and what motivates them for change. And so oftentimes I'll tell people in the first session or two is you're the expert. You far better than I will ever know you, and so you're the expert on you. And so what I want to do is to kind of go along with you and through this process, learn a little bit about what you're experiencing, and then maybe as we kind of collaborate through that, find some areas and some ways that you want to change, or some changes that you want to make to kind of get you where you want to be.
Awesome. So, and it's interesting hearing you talk about that, because it sounds like there's quite a few differences. It's quite different from kind of the older models. Right. Did you find that there was any sort of similarities in the way that you were approaching
Well, I think the general structure is very similar in treatment planning. You have goals, you have objectives, you have interventions, and so the structure really didn't change. It's just where do you get the information, and how do you incorporate, and what do you incorporate with that information? So where, again, a medical model kind of looks at, okay, you're having hallucinations, we want you to stop having hallucinations. Or, you have communication problems in your relationship, let's improve your communication problems in your relationship. And so as clinicians, we think a little bit differently than the people we work with about what they're going through. And so, we may be completely off base if we're just looking at it through the lens of, well, here's what I see you need to do.
Absolutely.
So, that's very problematic. And I think, again, knowing, just from research and things that the relationship that we develop with clients is the number one predictor of success. You're not going to develop a real good relationship with somebody if it's completely one-sided.
Right.
So.
Okay, so interesting. And so how does that look? So that's kind of how it looks for the clinician themselves, but what about in the institution or the place that you work? Have you seen a shift in kind of the way that the supervisors supervise or approach
Yeah, absolutely. And so one of the big things as part of the recovery-oriented practice in clinical mental health, when that came about and was kind of embraced and rolled out, is you started to see not just a shift in how we look at people and conceptualize cases, but also a shift in how we work with people. So where traditionally it's treatment is very prescriptive, and so do this, and you'll get better. In this, it's much more of a partnership, which is more in line with kind of some traditional counseling concepts.
Sure, absolutely.
As opposed to well, I went through treatment. Well, no, I participated in treatment.
Yeah, I was an active participant. In this.
Exactly. So in clinical mental health, you see things like peer providers. Something, never had that in the past.
Right.
And what a peer provider or a family partner or a peer specialist is somebody with lived experience. There's somebody that has a clinical mental health diagnosis, but has recovered through recovery-oriented care to the point where they work for us. They're an employee.
Right.
And they're able to, again, relate with clients on a level that, I don't have schizophrenia.
Sure.
I don't know what it's like to have schizophrenia. I'm bipolar disorder. I have no idea what it's like to have bipolar disorder. I may know intellectually what it is and how it works, but I don't know what it's like to live with it. And it's never the same for two people.
Right.
So what those peer specialists, where it's completely invaluable, is they're able to relate with the people that are receiving services in a way that clinicians can't.
Right.
Just foundationally, and they can develop relationships that are outside the norms of what a clinical relationship is. And so it's more, again, it's a peer relationship. It's in some respects, the substance abuse side of things was a little bit ahead of the curve. You look at things like sponsors.
Yeah.
It's a peer.
It's true.
And so, some of this recovery-oriented care bled from the substance abuse treatment side of clinical mental health into, more of the behavioral health component of severe persistent mental illness and things like that. And so I think that was a great thing, because at the end of the day, you kind of miss the boat if you're not incorporating the person.
Absolutely. Right. You're kind of expecting them to do things, but not necessarily including them in what those expectations look like.
Right. And looking at it through the lens of what I want for you may be completely different than what you want from me.
Or what's realistic for you based on your circumstances.
Right.
Sure. Wow. So how, in your opinion, how significant has the presence of that advocate or that additional person been in the treatment process?
It's huge, because it provides that additional level of support with somebody who's gone through it. But then you pair that with the change in the actual clinical practice for professionals, whether that's bachelor's level, licensed, or up.
Right.
Where everybody along that system of care is working with the person through the lens of, what do you want for you? What's important to you? How, say you experience trauma. Well, I might have a clinical perspective of how that's impacting you, but why don't you tell me how you think that's impacting you, and we'll work with your perspective on it, instead of just prescribing treatment based on symptoms.
Right. Okay. So
it's really treatment as an experience versus treatment as a process.
Right. And in your presentation, you also kind of touched on promoting recovery. So how, so having these advocates, these individuals come in, as a whole, as an institution or as a service provider, how else do you go about kind of making that a holistic approach to promoting that recovery? So it happens in the clinical session, but beyond that, how do you support that?
So we actually have standards specific to recovery-oriented care, and so it starts from the time a person walks in. We have a lengthy clinical interview and a process that kind of assesses a person's presenting problem. And we have formal tools and all the fancy clinical documents that kind of go with it, but what's built into that and what's so important about recovery-oriented care is it starts with the perspective of it's captured in the person's own words. It incorporates their values, their belief systems, their unique needs and their preferences for care. And so, we may think a person needs X, Y, and Z, but people have a right to say no.
Yeah.
And to say no without being abandoned.
Right.
If you're not going to follow what I want you to do,
fit in this box.
Yeah, exactly. And so, what I think that does for people is, from the outset, it allows them to experience going through a service system through the lens of, I'm a partner in this process, and what I say matters, as opposed to just being client number 165.
Right.
And so. We look at standards across that that's built into the documentation and the way that we go about assessing and treatment planning. And so all those pieces at each stage, at each phase of that process, take into account that individual's preferences, strengths, and belief system.
And so building on that, you also kind of, I heard you just say, it's important to hear kind of what's going on from the client themselves in their own words. And one of the things that you talked about in your presentation was this idea of being very intentional with the type of language that you use. So can you kind of expand a little bit on how important that is?
It's critical, because the language that you use when you conceptualize or you talk about people is a great window into what you really believe about that person.
Yeah.
And so clients or whether you call them clients or people or consumers or patients, whatever language you use, in talking about the people that you work with, the one thing that's important to recognize there is they're a person first.
Right.
They were a person before they had schizophrenia.
Mm-hmm.
And one of the things, kind of a litmus test for it, when I see, maybe people using non-recovery oriented language or we have a tendency, I think, sometimes as professionals to get a little bit salty or jaded, and to use dark humor and things like that is, say, take a 55-year-old gentleman who has schizophrenia, and most people look at that person and just see a quote-unquote crazy guy talking to himself under a bridge.
Right.
Say that person's homeless, whatever. Think about this. That was a 5-year-old once.
Mm-hmm.
That person had a mother, had a
Mm-hmm.
father, had a family, had wants, hopes, dreams.
Yeah.
And just because they developed an illness or have a problem doesn't necessarily mean that those things went away.
Right.
And that's what makes people unique. And so if you ignore that and you just focus on the fact that you have schizophrenia, you're dealing with schizophrenia, you're not dealing with a person.
You're not dealing with the person, exactly.
Right. And so how welcomed or engaged or hopeful would you feel if the only thing anybody ever talked to you about is what was wrong with you?
Mm-hmm.
Not very.
Right.
So that language is absolutely key, because if you don't use the language, do you really believe it?
Mm-hmm.
Do you really? It is a case conceptualization, or a conceptualization of a person and what they're going through. And so if your language is, well, that's a borderline, that's a schizophrenic, then you put people in this box that completely discounts their individuality.
Mm-hmm.
And you miss out on, if you don't explore those things, maybe a great deal of strengths and things that they could draw upon to have a better life.
Right.
But they define that. We don't define that.
Right. And that's kind of part of this whole idea.
Right.
And so what about from a supervision perspective? So because, recovery-oriented treatment planning and care is so intentional with the client and including them in that process, from a supervision perspective, do you find that you kind of have to modify the way that you teach or the way that you kind of do case conceptualization? Bless you.
Yeah, thank you. I think the shift there really occurs with, how do you conceptualize a challenge that in working with people? And so instead of, in a traditional model, you might look at it and say, okay, what new intervention can we do to deal with this problem?
Right.
Instead of, okay, this person has this strength, has this resource. How can they incorporate that into the process of being able to manage their own barrier or problem with some additional support? It's not that you ignore the more clinical aspects of, well, I need to shift my approach, or I need to try a different intervention or change medication, whatever it might be.
Right.
But you incorporate that piece as well, and that's what drives it.
Okay.
And so if a person, say, particularly in clinical mental health, when you deal with people that suffer from severe persistent mental illness, you'll hear a lot, there's tons and tons of research, and you hear tons and tons of talk about adherence, compliance,
Right.
take your pills, take your medication. If you don't do that, you won't get better. Factually, that's true.
Right.
We know that that's true, but it doesn't deal with the underlying issue of the motivation. So somebody comes in and they say, well, John just won't take his meds.
Mm-hmm.
He doesn't want to take his meds. We can't do anything for him.
Mm-hmm.
And so, and then you compound that with wrestling with, service production targets, and how do you manage the service delivery system. In a traditional model, you might be more apt to say, well, he's not engaging, so just discharge that person because they won't participate.
Right.
Where under recovery-oriented practice, you're going to look at that case and you're going to say, what can we do to motivate, to engage? What can we do to shift or change or strengthen the relationship? Maybe John doesn't want to take his medications not because he's non-compliant with treatment. Maybe he doesn't want to take them because he doesn't understand their role.
Mm-hmm.
He doesn't understand how that might help through his lens, through the way he looks at the world. So I kind of, one of the things I'll tell people is, look at it through the lens of people need to know the whys behind things.
Yeah.
And so part of that is it's that psychoeducational piece of, taking the time to explain things,
Mm-hmm.
not just to do things.
Right. And so a lot of times in graduate programs, they kind of teach you the foundation. So it sounds like what you're saying is when, you have new students come in or new clinicians coming in, you really kind of have to reframe their perspective on how they approach clients.
Right, and it absolutely, and I think graduate programs and modern programs that do an excellent job, and I can say that because I went through it,
right,
of teaching you to do that.
Mm-hmm.
But I think the challenge that new professionals have is they may walk into a facility or an organization or a system of care that hasn't fully embraced that.
Sure.
And so it's easy to fall into the trap of, what's, at least on the surface, appears to be most efficient versus what's most effective.
Right. So with that being said, if you have new students coming in or new professionals coming in and working under you, what kind of tips would you have for them if they wanted to work in a recovery-oriented program?
I would remind new professionals, particularly, therapists, that at the end of the day, don't forget what you learned, and despite what you face when you go out there. And at the end of the day, the way that you, and it goes back to theoretical orientation. How do we think about people, and that influences the way we provide care. And so don't lose that piece of they were a person first. They have unique needs, they have unique desires, they have dreams and hopes, and they have the right to fail. It's not just about what's going to be, what do I think is best for you. Efficiency.
Right.
You can be really efficient and be really ineffective.
Right.
You can roll through a process very cleanly and still not get a whole lot of change at the end of the day. And so, that partnership in working with people is critical. And so for new professionals, I would say when you look at things through, principles of intentional care and recovery-oriented practice, you can still apply that in a system that maybe isn't all the way there yet.
Right.
And it resides within your language and the way that you approach things and the way that you document things and the way that you relate to the person you're working with.
Awesome. So basically they can make that shift themselves without necessarily having it on an institutional level.
Absolutely. You may go into an institution that says, no, this is how a treatment plan works. Okay, well, again, that's kind of, the structure of a treatment plan is pretty similar, no matter where you're at. You have a goal, you have an objective, you have interventions. But again, the key there is in the language, and the language is a reflection of the belief system that's driving the work.
Right. Awesome. All right, well, thank you so much.
Oh,
we really appreciate having you here. We really appreciate your perspective. I mean, I think this is going to be really helpful for people. So thank you so much again, and I think we'll close here.
Sounds great.
All
Thanks,
right.
Julie.